هي مالها المشكلة المصيبة مش
Thank you very much, Professor Ola, for this nice introduction. I do thank very much Professor Shabnazari for his kind invitation to attend this conference to enlighten some really therapeutic issues from radiation oncology point of view about management of esophageal cancer. First of all, it's my honor to share Professor Mohammed Al-Qalawi, Professor Christopher Crane, Professor Mohammed Salim, Professor Osman Mansour, Professor Nasr Al-Aloubi this session, and I hope it's going to be successful. First of all, the value in oncology is always in balance, and it should be between the quality and the cost. From evidence-based medicine, we know that radiation therapy plays an important role with all grades of evidence, whether in the neoadjuvant or in the adjuvant setting. We know that the esophagus is composed of three components. We irradiate the esophagus from the cervical esophagus down to the GE junction. And the pattern of spread is mainly through the lymph nodes. That's why whether to give involved radiotherapy to the tumor itself or to include the lymph nodes is a debate, but recently it has been clear. This is the percentages of lymph nodes metastases according to the size of the esophageal tumor, whether in the cervical or in the mid-thoracic or the GE junction, highest in the GE junction. And interesting to note that there are different staging between the squamous and the adenocarcinoma. However, they have biological characteristic differentiation, but no radiotherapy dose differentiation. But there's been a lot of money have been spent for molecular targeted therapy from the medical oncology point of view. But for radiation, we did not pay any attention whether to modify or to dose escalate the dose of radiotherapy or not. So the problem and the solution of radiation is that we are always hitting a moving target. If we can see the target, we can hit it. If we can hit it, then eventually we'll be able to kill it. So the rationale of radiation is a high precision radiation therapy have to hit the center of the disease with increased dose to the tumor and very low dose to the organs at risk, which is the organs at risk like the heart, the lung, and the spinal cord. These are the problems in the esophagus. There is respiration, the lung moves, there is swallowing, peristaltic movement of the esophagus, and there's heartbeats. So all the structures within the vicinity of the thorax move within the portal of radiotherapy. So we have to be accurate, whether positioning, verification, identification and correction, and QA from the department. The goal is always to be accurate and precise. We have to deliver all the dose within the center of the tumor. This is the timeline of radiation therapy. It is 1960s, first in an accelerator, and now it is the 2000s. And coming up, we are shifting towards biological and targeted radiation and targeted chemotherapeutic agents. It's not working. Okay. This also enabled us from the imaging, enabled geometric targeting. With better quality, we can dose escalate, reduce toxicity, use hypofractionation by knowing more and more about the alpha-beta ratio. And voxelization, we are moving towards from a picture-based planning to a volume-based planning and a volume-based treatment, and adaptation during the treatment. So in radiotherapy, you have 5 R's. Did we study the radiosensitivity of squamous and adeno? However, the reoxygenation ulcerative pattern is not like exophatic pattern. Repopulation towards the end of the treatment, reassortment during the course of radiation, and repair. So the imaging, now we are shifted to a metabolic and molecular imaging, which enabled us for more and more target delineation. This is the CT simulator where we use to simulate our patients. The advantage of MRI and the PET scan is also an asset where you can delineate the esophageal tumor very nicely with the PET scan and draw your field with minimal dose to the surrounding structures. The radiotherapy is not a technique. The radiotherapy is a process. So it starts by proper immobilization, then image acquisition during the CT, and then we contour the structures, and then we treatment plan, and then we transfer the plan to the treatment machine, and then we validate the plan, verify the position, and then treat, and take a picture or a photo to be sure that what we have started with, already we are ending with.
So this is just to tell you, in short, that we need 7,000 CGY to treat a tumor with more than 4 centimeter adeno and 2 to 4 centimeter squamous, 90% survival in squamous and 60% in adeno. So the rationale of putting the dose of 50 gray only or 60 gray is not anymore the answer. The radiotherapy has got effects: acute, mainly mucositis; late fibrosis, atrophy, and vascular damage of the esophageal tumor and the surroundings. The dilemma of the esophagus that we have different anatomical boundaries. We have physiology, the pathology, whether direct invasion, intramural metastases in the mucosa, multicentric occurrent lesions, vascular invasion, and perineural invasion. In addition to the radiobiology, molecular biology, and molecular pathology and metabolism. All this has to be put in the context of the dose and the volume and the fractionation by radiation oncologist. This is just to tell you that to put a CTV, a clinical target volume, we have to, this was one study for the squamous, for the intramural metastases, we have to go cranial from 2.7 to 3.4 cm and coded 4 to 4.6 cm. For the adeno, it was 3.8 cm. So in studying the pathology, it is important to take the margin of our treatment. Whether we have 5 volumes of irradiation or 7 volumes, this is because we have a moving target. We have to draw the gross tumor volume and the clinical target volume, which moves, and then we have to put a planning target volume. But whether to put how millimeter for adeno or centimeter and for squamous, this has to be very much involved in. This is the ICRA recommendation, International Committee of Radiation in Units, that added to the definitions the internal margin and the safety margin and the organ at risk and the planning risk volumes. So we end up by 7 volumes, not 5 volumes. And we can use PET scan biologically determining the lesion itself. Again, functionality and radiobiology. The esophagus is a conduit, so if we exceed the dose, eventually we end in stenosis and collapse, and then radiation is a failure, not a success. The problem is in the tumor motion, diaphragmatic movement, peristaltic movement of the esophagus, heart movement, and lung movement. So radiation, we have got 4 pillars. We can play with the dose, the fraction size, the elapsed radiotherapy time, and the volume. And whether involved field irradiation better than taking the nodes with us? Yes, it is recommended. We have to take a clinical target volume of 3 centimeter sub-inf, and we have to take for the lymph node, if it is involved, 0.5 to 1 centimeter radial margin. And for the ITV, which is the internal tumor volume, because of the movement, we have to add 1 cm. This is eventually how we draw our disease, and then this is the box of treatment. This is 3D conformal. By placing 4 fields, you have to irradiate the lung, inevitably, and the liver, and the spinal cord. We have anecdotal data that normal tissue tolerance of the esophagus for the whole esophagus is 55, and for 1/3 of the esophagus is 60. So techniques is because of the LINAC accelerator. This is the gantry which move, this is the table that also move, and this is the beauty of the MLC multi-leaf collimator, which can independently move and to shape the tumor all through the disease, the tumor volume. For GE junction, the minimum recommended 3D margins is 1 centimeter radial, 1.5 cm distal, and 1 centimeter proximal margin. Typical radiation field for lower esophageal cancer is like this. So inevitably you are treating part of the heart, part of the liver, spinal cord, and part of the heart and part of the stomach, and part of the kidneys. So we have to shield all this. The beauty of the innovations of radiation is the IMRT. You can use static step and shoot, dynamic sliding window, where the treatment is continuously, the MLC is continuously blocking all through the treatment duration. And you can have a helical tomotherapy, or you have a VMAT, which is rotational. So these are the new techniques that can be adopted by the radiation oncologist in Center of Excellence Radiation Oncology Center. Not only this is the treatment, but we have all 12 inverse planning systems, which all of these add to the variation. Inter and intraplanar variation. If I draw the disease today and I come tomorrow, I might find myself drawing another thing, adding 1 cm or 5 millimeters. And again, Professor Dr. Awala sits beside me, she might draw another thing. So we have variation. All these have to be put in consideration by the quality assurance program. 3D versus IMRT. Of course, the IMRT can sculpture the treatment, especially if a concave light around the spinal cord. And we have shifted, as I said, from the picture-based to the volume-based treatment and planning. And IMRT terminology is a beamlet. We divided all the radiation portal, instead of a box 10 by 10, we divided like a chessboard into 100 or 200 small beamlets where you can intensify the dose and then eventually increase the dose to the tumor and very minimal dose to the surrounding. So there is a conformity index. You have to cover the tumor conformally, and then the dose inside the tumor should be homogeneous. This is the rationale. But in IMRT with simultaneous integrated boost, where you want to selectively increase the dose of the tumor, then you have to be heterogeneous, not homogeneous. This is a verification in clinical studies. The accuracy should be plus or minus 5% and 3 millimeters, only variation between the whole treatment duration. This is the VMAT. It is the linear accelerator that moves in a helical fashion in arc therapy. And the linear accelerator, we can modulate the MLC speed, the dose rate, the gantry speed. This is the only intensity modulation. And then the workload, about 18 working hours for each case. This is the tomotherapy. It's a helical, it's not like the normal linear accelerator, but the gantry is put inside the gantry like a CT scan, and then it can irradiate the patients nicely. This is the organs at risk that have to be paid in consideration: lungs, heart, liver, spinal cord, and the kidneys. And this is the new techniques, whether you use a fixed field IMRT or a volumetric modulated single arc or two arcs. You can let the treatment machine rotate in one arc or give two arcs. And this is to tell you that the volume of the 2 gray and 5 gray was less in the IMRT than from one arc. And the V20 and the V50 favor the only one arc, not the two arcs. And the treatment delivery time, which is important, it was 120 seconds versus 254 seconds for IMRT. So one single arc is better than intensity modulated radiotherapy. But the problem is that we have an integral dose and large tissue receiving the low dose region. So we have to pay attention to this, because if we are using the arc therapy, this is the contribution of the bone marrow in the human body. So eventually we are exposing 36 to 38% of the marrow, especially whereas we are speaking about concomitant chemoradiation standard of care, then the patient will be having neutropenia and blood problems. Whether one arc or two arcs is better, of course, the two arcs are better in coverage, but the one arc is less in the treatment delivery time. This is the arc therapy, and this is the rapid arc, and this is the IMRT. IMRT is multiple beams, but the arc is one single arc. If we add to it the helical tomotherapy gives a better homogeneity index, but the rapid arc, the single arc, gives a better reduction in the mean lung dose. This is again a very comparison between the IMRT and the one arc and the two arcs. And this is to tell you that eventually it is safe to increase the dose to the tumor with selectively decreasing the dose to the organs at risk if we use PET scan for delineation of the tumor itself. And this is ongoing, and it is safe, PET-based, acute toxicity is well tolerated. And can we optimize the radiation therapy regimens with the chemotherapy? We have to persistently develop early detection strategies, use targeted treatment, and biologically stratify our patients, and use brachytherapy very cautiously. Protons is again playing an important role, and from the Mayo Clinic, it is one of the indications of esophageal cancer. We have to adapt our therapy to improve the targeting and the organs at risk. Improving radiation is not only technique. This is 18 questions, where it's not only technology, it is patient selection, pathology stratification, genetic-based stratification, minimize organ at risk, manage organ motions, bone marrow dose, and less treatment time is better outcome. Each one of these issues is to be addressed by a phase 3 trial. Most of the technological trials are dosimetric analyses, because you have to collect 100 or 200 patients to see a difference in survival or local regional relapse-free survival. Thank you for your attention, and I hope it was useful.
Thanks a lot, Dr. Ihab Khalil, for this very descriptive lecture. And now for the second lecture by Professor Dr. Mohammed Kalhawi, Professor of Surgical Oncology, NCI Cairo, and the head of the unit of surgical oncology in Nasser Institute. The heading of the lectures is controversial issue in the surgical management of esophageal cancer. But because we have a limited time before the Friday prayer, please, for the speakers, we should be restricted within the 15 minutes. Thank you.
Yeah. I would thank the chairpersons and the particularly Professor Hisham Al-Ghazali for inviting me for this grand conference. We will talk about the controversial issues and indications, controversial issues in the management of esophageal cancer. Indications for esophageal resection and common techniques of resection and can be used for reconstruction and the routes of reconstruction and the extent of lymphadenectomy. We will start the preoperative assessment with history and physical examination and upper GT endoscopy and biopsy. However, we should pay attention to the C-word category, particularly for esophagogastric junctions, particularly for adenocarcinoma. And the potential surgical candidates should have careful pulmonary cardiopulmonary risk assessment, smoking cessation, and smoking cessation and physiotherapy started, and preoperative enteral feeding or TBN may be beneficial. The best tool for diagnosis of esophageal cancer is the endoscopic ultrasound. It would stage the superficial cancers, 80% accurate pathologic staging in TIS and T1 tumors, staging for advanced tumors and the lymph node status, and the fine needle aspiration cytology of the suspicious nodes and determining their resectability. The indications for malignant lesions are the carcinoma of the esophagus, whether it is squamous cell carcinoma versus adenocarcinoma, particularly in the lower esophagogastric junction, and the high-grade dysplasia in Barrett esophagus as a prophylactic measure, particularly in high-grade dysplasia with Barrett esophagus. This is the staging. Stage O, TIS, NO, MO. The best tool is the endoscopic mucosal resection with the 5-year survival more than 90%. And stage 1, T1, NO, MO, surgery is the best without preoperative or post-operative, without preoperative chemo irradiation. Stage 2A, T1 versus T2, NO, MO, surgery plus chemo irradiation. And stage 2B, T1, T2, N1, MO, surgery plus chemo irradiation. Stage 3, whether it is T3, NO, MO, T1, T2, N2, MO, T4, any N, MO, chemo irradiation first and plus minus surgery later on. With the survival in the stage 1, more than 70%, stage 2A, 15 to 30%, stage 2B, 10 to 15%, and stage 3, 6 to 10%. However, in stage 4, the survival is 0%. This is the treatment of esophageal cancer. as the slide before shows us that investigations, yeah. The acceptable operative approaches for resectable esophageal cancer or esophagogastric junction cancer, Ivor-Lewy operation, laparotomy plus right thoracotomy, McEwen gastrectomy, right thoracotomy plus laparotomy and cervical anastomosis. The minimally invasive Ivor-Lewy esophagogastrectomy, laparoscopy plus right thoracoscopy, minimally invasive McEwen esophagogastrectomy, right thoracoscopy, and limited laparoscopy plus cervical anastomosis. Transhiatal esophagogastrectomy, laparotomy plus cervical anastomosis. Robotic minimally invasive esophagogastrectomy. Left thoracic or thoraco-abdominal approach with anastomosis in the chest or neck. However, we abandoned these procedures, procedure 5 and procedure 7, since 1995. Indications for surgery for esophagectomy is usually performed with curative intent and should be considered for all physiologically fit patients with localized and resectable and thoracic esophageal cancer greater than 5 centimeters from the cricopharyngeus muscle and intra-abdominal esophageal or esophagogastric junction cancer. Palliative esophagectomy may be included as a component of palliative care for dysphagia or fistula. Salvage esophagectomy is failure of the primary treatment, the indication is failure of the primary treatment in absence of M1 disease. We choose the operations. The advantages of transhiatal esophagectomy is the surgical palliation in older and sick patients, reduce the operative time, avoiding thoracotomy, minimizes the cardiopulmonary complications. However, the disadvantage is hazardous for the middle third tumors and increased risk of bronchotracheal tear, increased risk of bleeding, blunt esophagectomy, increased risk of recurrent laryngeal nerve injury, particularly on the left side, high risk thoracic duct injury. Some authors consider that the middle third esophageal tumor is a contraindication for transhiatal esophageal resection. This is the transhiatal esophagectomy. To our team, it is not an oncologic sound operation, and we abandoned this procedure since 1995. And it does not guarantee a better short-term survival outcome and palliation. The management of intraoperative complications in transhiatal esophagectomy, the bleeding may be from the aorta, or the azygous vein, or the bronchial arteries. We should put a back and then upper sternal split. The tracheobronchial injury, secure airway by advancing an endobronchial tube and repair primarily versus pedicled flap. This is our patients' historical control. Patients historical control in our series. The number in the historical control is 56 patients. We, as I said before, we abandoned this procedure since 1995. and the transthoracic oesophageectomy, either Ivor Lowy 77 patients or McEwen 12 patients. This study ended in December 2010. There is no statistical significance difference. There is no statistical significance difference concerning the age or the sex or the associated disease. The associated disease is not analyzed as not statistically significant, and the preoperative therapy not analyzed because the limb here is empty and the limb here is empty, and tumor location cervical not analyzed for cervical lesions, and the upper thoracic showed no statistical significance, whether the upper thoracic or the mid thoracic or the lower thoracic or the gastroesophageal junction. Concerning the squamous cell carcinoma, it is not statistically significant. The adenocarcinoma is on the increase in the last 2 decades. And so it's statistically significant, shows statistical significance difference. And that the tumor stage, we haven't known stage O or 1 patients at all, because most of our patients are locally advanced. And stage 2A showed no statistical difference. Stage 2B, no statistical difference, and stage 3 also shows no statistical difference. Stage 4, we haven't deal with stage 4 patients. The overall morbidity shows statistical significance in favor of the transthoracic oesophageectomy, whether Ivor Lowy or McEwen's procedure. And also the anastomotic leak shows the statistical difference in favor of the transthoracic oesophageectomy, and also the sepsis from the anastomotic leak, and the recurrent laryngeal nerve injury, and the chylus fistula also shows a statistical difference in favor of transthoracic oesophageectomy. However, the other data concerning the surgical site infection or the post-operative hemorrhage or respiratory complications and renal complications and cardiac complications showed no statistical difference. Concerning the post-operative mortality, shows that highly statistical significant difference in favor of the transthoracic oesophageectomy. However, the ICU stay or the hospital stay showed no statistical difference. Concerning the survival, the 1-year survival shows no statistical significant difference between transhiatal oesophageectomy and the transthoracic oesophageectomy. And the 3-year survival shows statistical significance difference in favor of the transthoracic oesophageectomy. And also the 5-year survival shows statistical significant difference in the favor of the transthoracic oesophageectomy. This is Ivor Lowy, Welsh pioneer of the right-sided approach to the esophagus. The transthoracic oesophageectomy, transthoracic resection of the esophageal cancer could be performed through Ivor Lowy or McEwen procedure. Intrathoracic anastomosis have a significantly lower percentage of leak when compared to cervical anastomosis performed in transhiatal oesophageectomy. Why is the rate of anastomotic leakage is highest in the neck, albeit the luxuriant blood supply of the esophagus? In the neck, several factors could be accused. Ischemia or venous congestion of the highly drawn gastric tube, compression of the at the cervicothoracic junction, tension on the highly drawn gastric tube, pulling on the anastomosis. So what to do? Try to revert to an intrathoracic, well-drained anastomosis. If a cervical anastomosis is a must, ensure tension-free, well-vascularized anastomosis, preferably by a reversed ink bottle technique. This is the technique of ink bottle technique. The bottom excised from the mobilized stomach, and then the posterior outer row of Lambert sutures, particularly figure of 8, because the muscle coat of the esophagus has no support. And the posterior inner row with knots inside, and anterior inner row with knots inside, inverting the sutures, and the anterior outer layer. And the anterior outer row of interrupted Cushing sutures. Yeah. This is how to use the conduit. The advantages of the stomach is a reliable blood supply, gastric function preserved, excellent length, single anastomosis, relatively simple. Disadvantages: reduced reservoir function, regurgitation, increased risk of anastomotic leak, and usually it is the first choice. But what you can do in reduced surgery? This is the whether this is Ivor-Lewy or McEwen procedure. The colon, although the right colon is isoperistaltic and the luxurious blood supply, but however we usually prefer the left colon because it's more reliable blood supply, and though it is antiperistaltic, but excellent length and less prone to dilate, and the diameter is smaller. Exclude inflammatory bowel disease, polypi, diverticulosis, and the cancer by colonoscopy. Ensure good blood supply by biological testing of graft in vivo clamping using the bulldog clamps. And this is the colon. This is the roots of reconstruction. The best route is the posterior mediastinum. We don't prefer the retroesternal or the subcutaneous approach. The jejunum is advantage is peristaltic tube, no reflux. Disadvantages is the limited length, size, and the vascularity, and the needs of revascularization supercharged graft. We use only the jejunum for the post-glucoid carcinoma as a free vascularized graft. However, the advantages of the esophageal of the jejunum as a conduit is mentioned in the previous slide. The extent of lymphadenectomy, we have in Ivor-Lewy 2 incisions and 2 field lymphadenectomy. McEwen procedure 3 incisions and 3 fields. Transhiatal 2 incisions and accidentally transhiatal as accidental nodal involvement. Yeah. In patients undergoing ossification without preoperative chemoirradiation, at least 15 nodes should be removed for adequate nodal staging. In patients undergoing ossification with preoperative chemoirradiation, the optimum number of nodes to be removed is unknown, although similar nodes resection is recommended. In retrospective analysis, including about 30,000 patients with invasive esophageal cancer in SEEDS database, patients who had more than 12 nodes examined had significant reduction in mortality compared with those who had no has significantly lower mortality than other groups.
Please, Dr. Kalawi, 1 minute to finish your presentation.
Splenectomy with 3-field lymphadenectomy can be performed with low mortality and acceptable morbidity. Prevalence of the involved cervical nodes is high, regardless of the type of the location of the tumor, up to 12%. Patients with middle third esophageal carcinoma seems to benefit from 3-field lymphadenectomy. Distal third adenocarcinoma, 3-field remains controversial. Sentinel node concept in esophageal cancer should be reconsidered. This is the groups of lymph nodes to be dissected: bilateral cervical nodes, superior mediastinal and middle mediastinal and inferior mediastinal, and the abdominal nodes. As with other complex operations, pancreatic or liver surgery, the lowest mortality rates are achieved in high volume centers with high volume surgeons and the higher, steeper learning curve, accumulated experience, and availability of resources with multidisciplinary team. This is a study with minimally invasive. The palliative procedures are the photodynamic therapy, laser therapy, esophageal stenting, feeding genostomy, colonic interposition, external beam irradiation. However, the patient may need more than 2 palliative procedures. The take-home message: no matter approach is used, open or minimally invasive, esophagectomy is not a simple operation. The most accurate preoperative staging modality is endoscopic ultrasound. It is best determined in T and N. Immediate results are affected by numerous factors. However, long-term survival is not affected by stage. Is only affected by stage. Oh, sorry. Immediate results are affected by numerous factors. However, long-term survival is only affected by stage. Nodal status significantly alters the long-term survival. Tri-modality treatment, concurrent chemoradiotherapy, followed by surgery, is recommended for stage 2A, 2B, and 3. 15 to 30% of patients undergoing concurrent chemoradiotherapy will have complete pathological response. How to deal with them? Surgery versus follow-up. This era will be referred follow-up by endoscopic ultrasound. Intrathoracic anastomosis, intrathoracic esophagectomy has a significantly lower percentage of anastomotic leak with no severe mediastinitis when compared to cervical anastomosis done with transhiatal esophagectomy. In transthoracic esophagectomy, particular attention should be given to attention-free, well-vascularized anastomosis, preferably by reversive end-bottom technique. No single method of palliation is suitable for every patient. Most patients require more than one kind of palliative treatment to sustain the patency during the course of the disease. Team approach is essential for excellent outcome. And work hard in silence, and let success meet the noise. And success is a journey, not a destination. There is no elevator to success. You have to take the stairs. This is Cairo University at its construction, 1,908 years. Thank you.
Thanks, Prof. Thanks, Professor Mohammed Al-Kalawi, for this elegant presentation. And now we will move to the third speaker. The third speaker will be Professor Christopher Crane, He is going to speak about chemoradiotherapy in stomach cancer. Please, Professor Christopher.
Thank you very much for that kind introduction. I'm going to be talking about the role of chemoradiation in gastric cancer. I don't have control. Can you activate the slides? Okay, so I wanted to talk about the role of chemoradiation in the treatment of gastric cancer, the adjuvant treatment of gastric cancer. The most important controversy now is that there are two options, perioperative chemotherapy and postoperative chemoradiation. The rationale for the use of postoperative chemoradiation goes back to several sets of data, but I think one of the most important sets of data are the second look laparotomy series from the University of Minnesota. And this was before CT scans. The surgical group in Minnesota would do second look laparotomies after curative resection 6 to 12 months postoperatively in an attempt to remove any residual or recurrent disease, and they categorized where that disease was found. 107 patients were evaluable, and Lynn Gunderson, who's a radiation oncologist that trained about that time and was one of the most famous gastrointestinal radiation oncologists, when he was a junior faculty member in 1981, took the data and wrote a paper about where the recurrence has happened, and 84% of the patients had a component of local or regional failure. So this provided a very good rationale for the use of postoperative chemoradiation. Remember, this was in an era, in a 2D era, where the techniques were very, very crude, basically just anterior and posterior radiation fields with lower energy radiation, which gives very high doses to the critical tissues. But at that time, there were a couple of studies that were done with radiation that were very toxic, and the interest in the use of postoperative chemoradiation was diminished from that. So following that, adjuvant chemotherapy was investigated. There were dozens of studies looking at adjuvant chemotherapy with or without surgery, with or without adjuvant chemotherapy, and they were all negative. There was no clear benefit. During the time that was going on, Intergroup 116 was designed, which was a postoperative radiation study versus surgery alone with more modern techniques, taking lessons from what was learned from those earlier studies. And actually, I think it's important to point out that the most important lesson that was learned from those earlier studies, there was some treatment-related mortality from radiation. It was that you have to feed patients during radiation. If patients stop eating, they're going to get into trouble and they could die. So I think the most important message about this treatment from the supportive care standpoint is that patients have to maintain their caloric intake and their weight during treatment, and if they don't, then treatment needs to be interrupted. So anyway, that was understood, and things have treatment has been better tolerated, but it's still not an easy treatment to tolerate. I'll go through that and also go through the MAGIC trial, which also established a role for a different approach, which is perioperative chemotherapy. So meta-analyses have done about the postoperative chemotherapy trials, these earlier studies before the more modern agents, and there basically was, even in meta-analysis, very, very minimal benefit to the use of postoperative adjuvant chemotherapy. And Probably the most significant reason for that is that in the postoperative setting, most patients can't tolerate more than a couple cycles of chemotherapy, just because they all have nutritional deficiencies. Their PO intake is very limited. Most of them lose 10 or 20 pounds, and so it's very difficult for them to tolerate the postoperative chemotherapy component. Intergroup 116 was a randomized trial. It was initially published in 2001. Completely resected gastric cancer. Randomization was either observation or postoperative chemoradiation with 5-FU leucovorin followed by 4,500 Centigray with concurrent bolus 5-FU, and then followed by more 5-FU and leucovorin. This was with 2D radiation techniques, APPA treatment. And this was a trial of patients that were node positive. 85% were node positive. Most of them were more distal, so we're now seeing more proximal gastric cancer and GE junction cancers, but at this time the majority were distal stomach lesions. There was a very significant disease-free and overall survival benefit to the use of chemoradiation, as you can see, and this has been updated, and the results are essentially exactly the same. One important thing to realize about this is that in the study they recommended a D2 nodal dissection, but only 10% of patients got a D2 dissection. This was not non-compliance. This was patients were randomized after they were operated, so the surgeons didn't really even participate in the randomization process necessarily. So this is more pattern of care information in the United States at the time, and I think it's probably still about the same, is that the majority of patients operated by American surgeons in the community and in some academic centers do not get a D2 dissection. It may have changed somewhat since then, but this study was a study of less than D2 dissection surgeries, so D1 or even 50% got less than a D1 dissection. The thought has been since at that time that if the surgery is somewhat inadequate, if you will, that radiation makes up for that. Now, surgeons have argued, especially those that are proponents of the D2 dissection, that if you do a good D2 dissection, you don't need chemoradiation. I'll get to a study that's addressed that question. Now, this study, again, is difficult to tolerate for patients. There's very significant grade 3 GI toxicity and hematologic toxicity. In this trial were 3 deaths due to toxicity. And only 65% of patients could complete all of the treatment. However, it did establish the role of chemoradiation as a postoperative chemoradiation as an option that improves survival. The other thing that this study did mention is that it incorporated radiation quality assurance into the design, so that the radiation fields were reviewed by the investigators prior to the patient starting treatment, and they were corrected, but there were about 30% of the fields that needed to be corrected. So that was because most people weren't treating gastric cancer at the time. There's been a significant learning curve, and now I think most radiation oncologists are comfortable with the treatment of gastric cancer in this setting. There was a follow-up study to that, which looked at the use of ECF before and after instead of 5-FU leucovorin. That study was negative, completely negative, a CLGB study. They also changed the concurrent chemotherapy to infusional 5-FU. This kind of came at the same time as the MAGIC trial was being reported. It was designed about that time, but the ECF incorporation in the postoperative setting did not improve survival over 5-FU leucovorin. The MAGIC trial, which was published in 2006, was a perioperative chemotherapy approach where patients were treated preoperatively with ECF chemotherapy, followed by surgical resection, and then followed by 3 more cycles of ECF. It had a very similar survival benefit to the use of postoperative chemoradiation, with 36 versus 23% 5-year overall survival. You see the survival curves here. Most patients were able to complete the preoperative chemotherapy, but again, it was a challenge to complete the postoperative chemotherapy. Only 57% of patients completed their 43% completed their postoperative chemotherapy, and only 43% completed all 6 cycles. The main reason is the perioperative complications and difficulties with nutritional status and so forth. So the criticism of this trial is that only 42% of patients were able to complete all 3 cycles of postoperative chemotherapy, and despite a greater number of earlier stage patients in the MAGIC trial versus the intergroup 116, the progression-free survival and overall survival were slightly worse. But it's hard to compare across studies for sure. So what I think is a very interesting approach, given what we know about those 2 trials, is an ongoing trial called the CRITICS trial, where patients are given preoperative chemotherapy with ECF, followed by surgical resection, then randomization to either further ECF a la MAGIC trial or postoperative chemoradiation a la the intergroup 116 trial, with more kind of modernization of the radiotherapy and concurrent capecitabine, which should be well tolerated with cisplatin. Now, I'll talk about one of the biggest controversies now is whether or not chemoradiation or chemotherapy alone approaches would be better. And I think there are 2 trials. One of them is a GE junction trial, and one of them is a postoperative chemoradiation trial with D2 dissection. The so-called ARTIST trial from Korea was a randomized trial of patients who receive a D2 dissection, and of course, Korea is a country where gastric cancer is endemic, and there are high-volume surgeons there who perform good surgery. They were randomized to receive cisplatin or Enzalutamide versus chemoradiation with cisplatin and Enzalutamide as well. And here you see a difference in the survival curves after about 2 years. They begin to separate in disease-free and overall survival in the whole group that did not reach statistical significance. But there was a trend towards improvement in disease-free survival, 0.086. In the node-positive patients, there was an improvement, and you see in the lower panel, you can see the p-value is 0.0365 in the node-positive patients in it. And you can see at 5 years that the curves are separated by almost 20%. So this was not a planned subset analysis, but certainly it appears that in the node-positive patients there was a greater benefit to the use of postoperative chemoradiation, even with a D2 dissection. So I think this is still an open question in most people's minds, but in my mind, for node-positive gastric cancer with a D2 dissection, I think postoperative chemoradiation is indicated. The Koreans are repeating this trial in the node-positive patients. The other trial to point out is the STAL trial, which compared chemotherapy alone to neoadjuvant chemoradiation in the GE junction adenocarcinoma population. There was an improvement that wasn't quite statistically significant in the preoperative chemoradiation arm versus chemotherapy alone arm, as you can see by these survival curves. Now, the only thing that I'll mention, I don't want to talk too much about GE junction, but the only thing I'll mention, as the previous speaker mentioned, preoperative chemoradiation is a preferred approach for GE junction. So to me, that's not controversial, because the consequence of treating patients in the postoperative setting is that you really just can't do it, because here's an example of a patient who had initial surgery for GE junction adenocarcinoma, completed esophagectomy, anastomosis to the neck. The regions that are at risk are the tumor bed, the celiac axis, the gastric pull-up, and the anastomosis in the neck. And it's just almost impossible to cover all of those areas with adequate radiation dose without causing significant morbidity. So with preoperative chemoradiation, it's much better tolerated. So my conclusions are, in the STAL trial, preoperative chemoradiation established or showed that chemoradiation is superior to the chemotherapy alone. In the ARTIST trial, postoperative chemoradiation appears to be necessary for node-positive disease, although further validation of that is warranted. Radiation is debatable for patients who have D2 dissection who have nodes negative, and this is probably a minority of the patients, at least in the United States. The best results may be with preoperative chemotherapy followed by postoperative chemoradiation, and that's being evaluated by the critics trial that should be reported within the next few years. Thank you very much.
Okay, thanks Dr. Christopher for this very kind presentation about chemoradiotherapy in cancer stomach. And I think we postpone the question to the end of the session because if we have enough time. And now I have the pleasure to present next speaker, Professor Dr. Osman Mansour, Professor of Medical Oncology in IGILUC University. Dr. Osman will talk about the management of advanced cancer stomach in the era of targeted therapy.
Okay, thank you. My talk on the management of advancing gastric cancer in the era of targeted therapy. As you know, gastric cancer is a significant health problem in some countries where the crude incidence rate in males exceed 100 per 100,000 population. In Egypt, lies among the lower risk countries with a crude risk in males of around 3 per 100,000 population. And the patient with advanced disease have a median survival of less than 1 year, and the chemotherapy definitely improve overall survival compared with best supportive care by around 6 months. And the overall response to single agent chemotherapy rarely exceed 20%. Even for most effective agents such as taxanes and anthracycline and platinum compounds. And meta-analysis of randomized clinical trial definitely confirms the superiority of combination versus single agent chemotherapy. And as expected that combination chemotherapy with drugs such as platinum and 5-FU have an overall response rate around 20-30% of cases with a median survival of around 9 months. Adding a third drug like taxanes or anthracycline definitely augment the efficacy, and substitution of one drug for another reduce or increase the tolerability, but this definitely occur at the expense of higher cost. And the role of second-line taxanes have been evaluated in 2 trials. In COGAR trial, patients were randomized to receive docetaxel versus active symptom control, and in this trial, definitely docetaxel have been shown to improve the overall survival from 3.6 to 5.2. Actually, 1.6 survival gain is not huge, but this indicates that at least a subgroup of patients who did not receive taxane can have improvement of their survival when used at second-line therapy. And in second trial, which is performed in Asia, this group of patients, docetaxel or irinotecan, were compared with best supportive care, and in this trial, both drugs have been shown to improve the overall survival against best supportive care, with no significant difference between docetaxel and irinotecan lines. And dose-dense paclitaxel have been compared directly with irinotecan in phase 3 trial, randomized trial in patients with prior fluoropyrimidine and platinum-containing regimen. And in this trial, weekly paclitaxel have been shown to improve the overall response rate, but this improvement did not reach statistical significance. There was also no difference in survival data as regards progression-free survival or overall survival between the 2 drugs. Actually, gene expression profile and as a part of Cancer Genome Atlas project, including 299 patients, shows that HER2 overexpression can be detected around 30% of cases, which is more proximal than distal subtypes. KRAS, BRAF, and CMET can be overexpressed in around 5 to 10% of cases, while EGFR has been shown to be expressed in around more than 50% of cases where a mutation in less than 5%. And as an invitation for HER2 testing, we should notice that patients with HER2 staining of gastric and gastroesophageal junction may be complete basolateral or lateral in nature. This is in contrast to breast cancer, where immune staining should be complete, and this is mainly due to low structure of the low-grade gastric adenocarcinoma. And actually, there is heterogeneity in the expression of HER2 in gastric cancer that reach around 30% of cases, and the screening of entire specimen is required for FISH analysis for at least 6 biopsies should be analyzed before concluding if it is positive or negative. And the methodology for interpretation of the results follows that as we usually used for breast cancer. Patient with immunohistochemistry score 2 should proceed for FISH, and those with positive for FISH should be proceeded for anti-HER2 therapy. And should notice be that immune staining should at least more than 10% of tumor cells in case of surgical specimen, and can be considered positive irrespective of number of cells in a biopsy specimen. Actually, we have a lot of anti-HER2 directed therapy, including trastuzumab, lapatinib, TDM1, bertuzumab, and neratinib, and everolimus. In TOGA trial, trastuzumab has been evaluated in combination with chemotherapy versus chemotherapy alone in patients with HER2 positive disease. And in this trial, trastuzumab have been shown to definitely improve the overall survival versus best supportive care. And this benefit has been shown to be extended to other secondary endpoints, which include response rate and progression-free survival. Trastuzumab does not have impact on overall safety profile. This is true for renal, hematological, gastrointestinal, and cardiac toxicity, with no increase in the incidence of cardiac-related adverse event leading to death between the two arms. And for the first time, we have a drug that can extend survival beyond 1 year. Beyond that, trastuzumab, lapatinib has been evaluated in phase 3 trial as a first-line therapy in combination with cereplatin and fluoropyrimidine. And in this study, lapatinib did not meet the primary endpoint of improvement of the overall survival. And in second trial, lapatinib has been compared as a second line in combination with paclitaxel in patients with HER2 positive disease. And again, lapatinib failed to have an impact on survival. That's true for overall or progression-free survival. Role of trastuzumab after a success story of bertuzumab, combination bertuzumab trastuzumab in patients with breast cancer, a similar approach is under current evaluation in patients with advanced gastric carcinoma. In this group of patients were randomized to receive either bertuzumab trastuzumab combination with chemotherapy versus chemotherapy and trastuzumab alone. The role of TDM1 was an antibody drug conjugate. Is the trastuzumab bound to cytotoxic chemotherapy that retains the trastuzumab antibody-dependent cellular cytotoxic action and immediate internalization and release of mirtazapine, which is a potent cytotoxic drugs with high lethal to malignant cells. And TDM1 is under current evaluation in 2 dose level 2.4 and 3.6 compared with combination containing paclitaxel or docetaxel according to investigator choice. Everolimus have been evaluated in phase 3 GRANITE trial, and the study was negative. As you can see here, the curves are overlapping. And EGFR, as we told before, have been found to be overexpressed around 60 to 80% of cases. The small TKI gefitinib was negative in a small trial from UK. Cetuximab and imatinib has been evaluated in 2 trials, that EXPAND and RAIL 3 trial. In EXPAND trial, cetuximab in combination with capecitabine and cisplatin versus the chemotherapy alone. This trial was negative for overall survival. And in second trial, the RAIL 3 trial, EOC with banitumab has been compared with chemotherapy alone, but should be noticed that the blinatumomab arm containing a modified doses of chemotherapy with reduction of oxaliplatin and capecitabine doses to 100 and 1,000 gram per square meter instead of 130 and 1,250. And in this study, there was no difference in response rate between the two arms, and surprisingly, the blinatumomab arm showed trend toward inferior progression-free survival, which reached statistical significance in patient for overall survival, and the blinatumomab arm was definitely inferior for survival compared with chemotherapy alone. Whether this is due to the reduced doses of chemotherapy in combination with blinatumomab or for another reasons still unknown. And as we know from this study and other studies that increased level of vascular epidermal growth factor following gastrectomy convey a poor prognosis. It's logical to use the anti-angiogenic drugs in treatment of advancing disease. And this trial, Avagast trial, bevacizumab has been compared versus placebo and combination of chemotherapy. Patients who at least stable disease or responding are allowed to continue on either capecitabine or combination of capecitabine and bevacizumab. And this trial definitely showed improvement of median progression-free survival and overall response rate, but without survival gain. Actually, patients outside Asia and those with high risk, more than one risk factor, which including prior gastrectomy, business bone metastasis, and standard type histology, and peritoneal metastasis, have improvement of overall survival in subgroup analysis. Ramucirumab is an IgG1 monoclonal antibody that binds the extracellular domain of vascular epithelial growth factor receptor 2, and not only block the binding of vascular epithelial growth factor its ligand, but also inhibit receptor activation and signaling. And ramucirumab has been evaluated versus placebo in phase 3 trial, that's the REGARD trial, in around 346 patients. And this trial, ramucirumab has been shown to improve the overall survival and progression-free survival, and this benefit, as we can see, as expected from anti-angiogenic therapy, hypertension is a significant increased with anti-angiogenic therapy. In a second trial, ramucirumab has been evaluated in combination with paclitaxel versus paclitaxel alone in patients with advanced disease as a second line, and this study again ramucirumab has been shown to improve the overall survival with significant p-value, and this benefit has been shown to be extended for both group of patients below and above the age of 65. And as regards second endpoint was the progression-free survival, again ramucirumab has been shown to improve the survival, and this benefit again extended regardless of age. Actually, more patients on ramucirumab arm discontinued treatment due to adverse event, and but the number of patients discontinuing treatment because of adverse event is similar in both age group, regardless of the treatment given. And the multi-kinetic oral multi-kinase inhibitor regorafenib has been evaluated against best supportive care, and in this study, regorafenib has been shown to improve the progression-free survival, but does not impact the overall survival, and the drug definitely is associated with significant hypertension and abdominal pain compared with placebo. Other important pathway is the hepatocyte growth factor MET pathway, and in this pathway definitely is mediate the malignant cell proliferation, survival, and invasive. And actually we have two policy to target this pathway, either target its receptor for drugs such as onartuzumab or bind its ligand with relutamab. Data on onartuzumab has been evaluated in combination with Filfox versus Filfox alone, and this trial was negative, with no significant improvement of progression-free survival or overall survival, even in patients with high MET expression. And definitely the drug was associated with higher thromboembolic events compared with placebo. And the second trial, relotimab, has been evaluated in combination with ECX regimen, and in any analysis of this trial, which revealed that c-MET overexpression can be detected around 42% of cases. And in this group of patients, there was a trend, early analysis of this study. Actually, this early analysis, after 120 patients enrolled in this trial, revealed the trend toward improvement of overall progression-free survival, with nearly doubling the overall survival. However, with further recruitment of patients in this trial, the study was closed because of lack of survival benefit. Similar trial has been conducted in with relotimab in combination with ECX regimen, and this trial again was stopped prematurely because of lack of survival benefit. Actually, gastrointestinal is not a single disease, and the gene expression array shows that we have at least dealing with 3 types. Type 1 is driven by inflammatory pathway. Type 2 is caused by inherited CDH1 mutation, and type 3, intestinal type, is related to Helicobacter pylori infection. And although there is an overlap in gene expressed between normal and malignant tissue, there is a specific gene that is expressed preferentially by each subtype. And as we see here, as a part of gene expression array, as a part of the Cancer Genomic Atlas project, enable us to classify cancer stomach into 4 distinct subtypes. Those with chromosomally unstable, commonly seen in patients with intestinal histology, TP53 mutation, and chromosomally stable, genomically stable, which is associated with diffuse histology, CDH1 mutation, macrosatellite unstable, associated with hypermethylation, MLH1 silencing, and increased mitotic pathway, and those with Epstein-Barr virus related, associated with the PI3K mutation, and increased expression of JAK2, PD-L1 and 2. Actually, the role of immunotherapy is going to be covered by Professor Dr. Mohammed Salim, and I am going to stop here and thank you.